Good evening. Welcome to Health Innovators. My name is Cal, and we've been operating Health Innovators for the past 14 months. We have hosted 20 plus events in the past 14 months, and we have provided the gift of education and collaboration to 2,000 people. Thank you. Well, for the past 14 months, we have added value to our community, but we have never expected anything in return. But now, we need your help. We offer a slew of services, and we want you to collaborate with us. We offer patient satisfaction app, we are offering that free for you to download and to our community, so that you can download and you can tell your friends to download. And we also have a telemedicine application where we offer nurses, and we're giving that for free to eligible nonprofits. We have an ICD-10 mapping tool. We have custom software, web and mobile development, and we also offer healthcare marketing and communication. Well, please consider collaborating with us, because we have big plans for this new year. We want to open an incubator here in Cambridge. We want to open 10 local chapters all around the country, starting with New York, Chicago, and Los Angeles. So please consider collaborating with us. Well, that's my elevator pitch for tonight. Thank you. Well, let's get down to business. Let's talk about meaningful use. Well, a few months ago, my friend Ann called me and said, "Hey Cal, I'm hosting a party for Don Berwick. Do you want to come?" Then I said, I like parties, but can you please tell me more about Don? Then she said, "Cal, Don is a great guy. I've known him for 20 years, and he's a man who lives his life with the highest values and belief system. Don has impeccable integrity." I said, "Wow, I need to meet him." So I went to Ann's house party, and that's the first time I met Don. And I was so impressed by Don. And I said, wow, not only he has strong personal values, but he's very competent. He ran Institute for Healthcare Improvement for 20 years. President Barack Obama was so impressed by him, he called Don and said, "Hey Don, I want you in Washington right now. The healthcare system in America is broken, and I want you to fix it." And Don said, "Mr. President, you just called me out of the blue, but let me think about it." And Don thought, by running CMS, I could save many more lives, and he took the job of running CMS, and the rest is history. But Don is a fighter. He's embarking on another challenge. He likes to fix things. He's a problem solver. He's running to be the next governor for the state of Massachusetts. He wants to fix a lot of things. He wants to make our healthcare system even better. He wants to fix transportation, environment, and many other issues. Well, with your support, we can help Don to fix all these issues. He has an impeccable track record, and I hope you support him. Without further ado, I would like to invite our next governor for the state of Massachusetts, our beacon for hope and champion for change, Don Berwick.
Thank you so much, Cal. And now I have a real problem, because I'm going to vote for you. Thank you so much for the chance to join you this evening, and thanks for your leadership in the sector that we depend on so much now in healthcare and actually in every other domain of our public and private lives. And Dr. Kawa, thank you for your introduction and for your leadership. You've heard a little bit about my background. It is, as you've heard, I'm a pediatrician, actually. I'm a doctor. I practiced pediatrics for 22 years at the Harvard Community Health Plan in Kenmore Square, and also as vice president there working on quality of care. And the story that Dr. Kawa was telling you about is about my development of interest in systems and improvement and how productive change happens in complex arenas, including healthcare. And that's what I devoted my life to for the past 30 years. I founded and ran and grew the Institute for Healthcare Improvement, IHI. Some of you may know it. It's on IHI.org. It now is the, I think, the most significant nonprofit in the world working to make healthcare better. And I'm very proud of that work and glad to work with hundreds of colleagues of yours all over the world in 3 or 4 dozen countries and in every state in the Union. And the story is that, as Dr. Kawa said, I was asked quite out of the blue to come down to Washington and run Medicare and Medicaid, the Centers for Medicare and Medicaid Services, shortly after the president was elected. I did go down there. My confirmation was blocked by Republican opposition to the president, but I did get to serve running CMS for 17 months, and an amazing experience of trying to work toward social justice and healthcare as a human right and better healthcare in America. I felt so fortunate to be there. My recess appointment, which the president used to get me there, it's a constitutional provision that allowed him to give me the job without Senate confirmation, pending potential confirmation, which never came. Under presidential appointment, the Constitution time limits that. So I left that post, came back to Massachusetts in December of 2011, after the most marvelous year and a half I've ever had in my career. Determined to stay in the public sector and try to help accelerate improvements in the nation and in Massachusetts for our own sake and as an example for the world, and we'll talk about that later on. I need to confess something, which is Cal asked me to speak about meaningful use, and I'll tell you what I know about that as of now, but you may know more than I do. Let me explain why. In December 2011, December 2nd, 2011, I left Washington as a presidential appointee, then a post-presidential appointee, and an ethics prohibition enters my world at that point. For 24 months, 2 full years, I was prohibited under criminal penalties from communicating back to HHS in any substantive way. So there's a blank window for me starting in about 2 years ago, during which time you may have tracked meaningful use more than I did. I do have friends and neighbors and colleagues in that world, and I'm very interested in it. And since December 2nd, 2013, I've reconnected a bit. But I want to caution you that what I now know about meaningful use and where it's headed is less than you may if you have been in continuous touch with HHS. But Cal's right. I did have responsibility in CMS for implementation of many provisions of the Affordable Care Act and the relevant statutes that underlie meaningful use, the Hitech law, in a relationship with the Office of the National Coordinator. So the National Coordinator, think of it as the design firm, coming up with the policy frameworks and the technical vision, and CMS is one of the key implementers of that through our incentive programs, our payment systems, our research programs, and so on, and that's the basis on which I'm telling you about meaningful use. In order to explain where I think we are and need to go in meaningful use, I need to zoom out, because the only way to think about technology and healthcare of any type, and meaningful use in particular, is as a pillar, an element of a far broader plan, which is to make healthcare become in America what it needs to become. We are under 2 majestic enterprises right now in this nation, in my view, with respect to what healthcare needs to become. The first thing we're trying to do in this nation is make healthcare a human right. We're the only Western democracy which does not do that. We're the only place that has said if you live here just as you can, entitled to life, liberty, and the pursuit of happiness, you can have health care. It's the charter of human rights in our country. We're the only country that hasn't said that, and now we're on the threshold of doing that. So the Affordable Care Act, for all of the drama and opposition you're seeing, I see it as a step in that direction, a majestic step toward saying that if you're here, you have health care. 50 million Americans lack health care. Under the Affordable Care Act, if it were completely implemented, it would be 32 million of those people would be covered. It still leaves a gap, but it's a big step forward. And one of the reasons I feel lucky to have been in Washington was I got to play a role in helping to make that come true. And we will make it come true. Our state, I would like to point out to you, made healthcare a human right in 2006. with legislation that we did at the state level. So this is the only state in the union that can now say we have full coverage. 98% of adults, 99% of kids have coverage. That's majestic path one. The second is changing healthcare, because healthcare, as it was built and developed over the centuries in our nation and other nations, is not today fit for the task. It was built in a way that might have been right for the time, but is wrong for our time. It was built in fragments and pieces, and that's reflected in the way we pay for it. We pay hospitals to have you in a bed. We pay doctors to have a visit with you. We pay ambulance companies to put you in the ambulance, and we pay specialists to run the MRI machine. We pay in pieces. But the social need isn't for pieces. It's for journeys. It's the big problem in American healthcare that we're trying to solve, health. It relates largely to chronic illness, and people who have diabetes or congestive heart failure or chronic lung disease, they're not in events, they're in a journey through their lives. Their hope is to attend their grandchild's graduation and enjoy the Downton Abbey and be able to play as much tennis as they possibly can, even if they have congestive heart failure. They're in a journey in their lives, and the job of healthcare is to help them make that journey as well as they possibly can for as long as they possibly can. And that's about 70% of our healthcare costs. And you don't do that with pieces. You can't do that with fragments. Of the thousands of hours in one's year, a tiny portion of them are spent in healthcare. We need to think in a much more integrated way. We did not build a system for continuity, coordination, teamwork, and health. And that's the other major defect in the system. We didn't build the system to keep you from getting sick in the first place, because almost all the ways you get sick are strongly determined by things that don't have anything to do with healthcare. They have to do with what you eat, and how you exercise, and substance abuse, and actually justice and equity and poverty in your society, the air you breathe, the streets you walk on. And we never built a system that said, instead of treating your heart attack, we preferred that you didn't have it in the first place, and we'd like to help you get there. These gaps in chronic illness care and continuity and prevention are serious gaps, and they're extremely expensive, and that's really the third problem. Chronic illness care, prevention, and cost. We have a system it's basically become unaffordable. We're at 18% of the gross domestic product, 40% more than the next most expensive country on earth. At least 30 or 40% of that expenditure is waste, and we know that now from formal reports from our National Academy of Sciences. In Massachusetts, we had a report last week from our healthcare commission saying 30% of the care is waste. That's because when we drop the ball, when we don't build the care for continuity and journeys, the care gets more expensive and worse. It's just like anything else. If you buy a car that's a lemon, you're going to spend more than if the car works right. Well, if you buy healthcare that's in pieces and fragmented and doesn't tell stories about people, it doesn't help keep you well, it doesn't help you through your journey, we will pay more because the complications will rise and the miscommunications will rise and the duplication will rise. In addition, we built a lot of excess administrative costs into healthcare. We could get out of it. With that much not value-added work in healthcare, with the needs so clear, and with the wonderful examples we have around the country and around the world, we actually know what better care looks like at lower cost. The example I've been quoting often since I was most recently there in Anchorage, Alaska, is the NUCA system. And those of you interested in technology, you might want to look at NUCA, N-U-K-A. It's the Alaska Native Healthcare System in Anchorage, Alaska, where I worked. I saw kids in the Indian Health Service when my wife had a sabbatical year in Anchorage. NUCA is the other kind of system. Integrated, team-based, home-based, organized around wellness, trying to keep the Alaska Natives, 60,000 Alaska Natives in the Anchorage Bowl, as well as they possibly can be for as long as they can possibly be. The last thing NUCA wants to use is a hospital bed. It wants to find all the other ways to make you strong and capable and keep you well. The results are astounding. NUCA in 5 years, started about 2002, in its first 5 years, it reduced hospital use 53%. It reduced emergency visits 50%. It reduced specialty visits 65%. And all that time, the outcomes improved and improved and improved. They now have the best quality scores probably in the country. They were superior care with the highest satisfaction of staff and patients and community they've ever seen. They're building care right. To do that in America as a whole, we have to redesign care. We have to have health care reform, not reform, reform. We have to make it different, new, continuous. It has to have a memory and a brain. It has to know where you are. It has to remember that this guy gave you that medicine and that woman gave you that other medicine. It has to have a sense of journeys in it. And it really has to be oriented around education and support for the people that care for you and for you yourself. we have a lot of changes we're going to have to make in order to get to that healthcare system. And in this state, it's crucial. As I'm running for governor, I can see the healthcare costs and what they're doing and eating into everything else that we'd like to do. 25% decrease in our budget for higher education, 25% decrease in our budget for early childhood, 30% decrease in our budget for parks and recreation over 10 years. Healthcare up 59%. So what's happening in public finance is that all the money's going to healthcare and coming away from other things we really, really need to do with and for each other. And if you're in the private sector, you see the same thing. I met earlier today with the owner of an important corporation in this Commonwealth, and he just talked about his healthcare bills. He can't pay it. He wants to cover his employees. But with rises like that, handed an 18% increase in his premium by an insurance company, he doesn't know how he's going to stay in business. So it's a public and private sector problem. The good news is we know the answer. And it's building systems that actually are about people, that actually are about continuity and help and education and growth and development and wellness. So we have to change a lot. We have to change the payment system. So instead of paying hospitals to stay full, we have to find out a way to pay for them to be empty. Where hospitals get really interested in the idea, hey, we can keep you home, we don't need you in this bed. If you show up tomorrow and propose to the head of one of the big healthcare systems in Massachusetts that you found a way to reduce hospital admissions 53%, that will be a very short conversation, because the whole revenue and business model depends on staying full. We have to change that. We have to move toward payments that are global and more about population care, pay more for prevention and primary care, integrate mental health care into the center, because that's the only way you keep people well. And we have to probably change dramatically our insurance system. In my campaign, I've proposed that we need to look at single payer systems in this state. Well, there are ways to do that. I'd like to figure out how we might do it. I think it would be one way to get administrative costs far lower. We have to change training. We're trained now for specialization and fragmentation. We have to change that education system. We have to change public beliefs and knowledge so people understand what wellness really can be, how good the care could be, instead of just assuming that more is better and that this something is taken, is decreased, it hurts them. It doesn't, it helps them not to have a unnecessary drug or treatment. We have to change the buildings and the structures, because a lot of the care we need isn't in hospitals, it's at home. But we also have to change information systems, and that's where you come in. It's a core asset, resource, in shaping the care we ought to give. And we've seen the progress that we made. I worked deep with the Kaiser Permanente around their core information change, which has been phenomenal, where they say home is the hub, not the hospital, not the medical record, home is the hub. I watched utilization rates fall as patients become more educated about what they know. We know, for example, that if you engage patients in shared decision-making, you tell them all about the options they've got, medicine or surgery or this way or that. We know from research done by Annette O'Connor in Canada that studying literature all over the world, that you get a 23% decline in surgery rates by involving patients in their care and better outcomes, because people are asking tough questions about what's going to happen to them and what they really like in their lives. That's going to involve change in information. But we're not there. We're not in the modern age of information. My laundry is more automated than my physician's office, than most physician offices. My pizza parlor has a data system that most doctors' offices don't. When we decided to change that, I actually served on the first Institute of Medicine committee on the future of the patient record, talking about electronic records, for example, 35 years ago. We called it urgent. And but that's changed now. With the Hitech Act and real leadership, presidential leadership, congressional leadership, leadership from you, from the people that actually do the technical work, we're starting to really make a difference. And we bottled that under a set of terminologies, one of which is meaningful use. But you will not understand meaningful use if you don't zoom out and see the big picture about the new healthcare we need. Meaningful use is relevant only in the context of making care better for people. So what happened? Well, we passed a law, the Hitech Act, and the Office of National Coordinator became the center of action, and that under David Grailer and his successors, and my friend David Blumenthal, and most recently Farzad Mostasari, and soon the new nominee, a brilliant doctor from New Orleans. We're trying to set in place a kind of national architecture, thinking and action for the support of evolution to electronic records. The architecture is brilliant. I think it's got the elements we need. There's an idea of visioning about the direction we're going, standard setting, and most importantly to me, helping relationships. The health insurance exchanges, HIEs, which are going to try to come up with common platforms for sharing data, and the regional extension centers, the REC 62 regional extension centers that are there, just like the Agriculture Extension Service was first for farmers, now real places where people who would have trouble accessing the kind of knowledge you have to get together and learn. David Blumenthal designed this, decided to try it in stages. And so the idea was, let's walk our way into the future. And stage one, you're probably very familiar with. Stage one of meaningful use, stage one of the evolution of progress toward a modern healthcare system, that's a stage of adoption. It's a stage of commitment, of incentives and other supports that would allow us to say, okay, let's do it now. That's how stage one played out. It includes incentives, so that it's interesting for doctors and hospitals especially to get involved. It includes support systems like the RECs, the regional extension centers, and support systems for technologies and data exchange like the health insurance exchanges. It's a minimalist stage. It's a stage of saying I'm going to be in the game, which seems logical to me. It looked right to me, and I was involved in the writing of the regulations then. It said the ONC, Office of National Coordinator, had the idea. Now here are the CMS rule base that will help you go there, which included incentives, positive incentives, rewards, mostly to doctors and hospitals that would get to stage one and qualify. The stage one standards, they look pretty high mountain for a lot of doctors and hospitals. You know them, automated relationship of prescribing to the pharmacy, warnings about drug-drug interactions, guidelines and reminders, computerized physician order entry, standardized lists of allergies and problems and medications. Simple basics, the basics of an electronic record. It was not clear what was going to happen. I was kind of worried as we got into this what would happen. What's happened has been a good story. As of now, as of July, which is the last I saw, that's Farzad's testimony to Congress in July, 293,000 providers, physician providers mostly, 50% of all the providers in the country met stage one meaningful use criteria, got the incentives. 3,900 hospitals, covering 80% of all the beds. That's a massive change. That occurred in a very short period of time. 145,000 primary care providers signed up with one of the regional extension centers. That's 40% of all the primary care providers in the country. So you think about that, you may lament the gap, but my goodness, this was a massive change that 30 years ago we said we would do and made no progress at all until this happened. An index of adoption would be CPOE, computerized physician order entry, which we know reduces complications. We have the data. In fact, a lot of the peer research came in right out here, out of the Brigham Hospital, here with David Bates and his colleague. They weren't alone. Between 2009 and 2012, we went from 45% of doctors using computerized entry to 80%. We went from 27% of hospitals using computerized order entry to 72%. So make no mistake about it, we're on a roll, and what we're doing is working. In the regional extension centers, one of the pieces of data I have is that a physician who signed up to get help from the regional extension center was 230% more likely, 2.3 times more likely to actually get the incentive than the ones that didn't use the benefit of this national learning system. It's extraordinary. 80% of federally qualified health centers have signed up with a rep, which is fantastic. I mean, the FQHCs myself, if I were in your field, I would just be pouring energy into the qualified health centers because they could be the engine of the new care if we do that right. Problems have surfaced in phase one, including how do small physician practices play. 85% of the care in this country, 85.5% of the care is given by physician groups of fewer than 10. So we have to have a way to get to people that don't have a lot of capital, they don't have access to capital, and still get them into the meaningful use world, and the incentives have helped, they haven't solved the problem. I think workflow integration is an issue. In fact, now if you've been reading the New York Times, when sometimes hospitals go to electronic records, the work slows down, and frankly, some pretty nasty games start, where the system is used for upcoding or for playing games with billing instead of actually helping patients. We're going to have to get mature and work our way backward out of that problem. And I think the big issue is the interoperability. We decided to use a pluralistic vendor system. I'm probably talking to some of you, and I think there are thousands. Is it 1,000 medical record vendors in the country now? 900.
Not 2014 certified.
not 2014 certified, nor will they be if we do this right. We had the Great American Festival of Individual Entrepreneurship without remembering, and hey, we're in this together. And I think even Epic doesn't interface very well with well, that's a mistake. You can't live with that. You go out there, as I do, to the doctors and nurses and hospitals, and the thing they want is interoperability. I have a home in a small village, Plymouth, New Hampshire, where it's the whole town, I don't know, it has maybe 15,000 people. It's a small town. There are 4 physician practices in 1 hospital and 5 record systems, and they don't talk to each other, and it just makes no sense. So we have to get out of that box. So stage 2 is about that. We have the diagnoses now. From the Commonwealth Fund survey in 2012 of primary care doctors, only 1/4 of primary care doctors say that if their patient goes to the emergency room, they get the information the next day. 1/4. In Denmark, it's 100%. Only half of the doctors in primary care say that they have a hospital discharge information on their own patient from the hospital within 48 hours. 10% of primary care doctors say they would know if a specialist they referred a patient to changed their meds. So it's a rather serious problem. Bravo, we have adoption. Now, next step, interoperability. And that's what stage 2 is about. It's about the exchange of information, 2 kinds of exchange. Provider-to-provider exchange, so that doctors would know what each other are doing and the hospital knows when the patient goes home. And so it's all that information across the spectrum of care. And even more exciting to me is interoperability in patient interfaces. In my opinion, it should include complete access of patients to their own medical record. I've felt that for 20 years, that would be a major step forward, not at this tiny little keyhole window. You want your record, it's your book, not mine, you can have it. But we can at least go as far as helping patients secure the information they want and secure messaging between the physician and the patient. And I'm delighted that that's in stage 2. So the idea that you to qualify in the 2014 stage 2, if I read it right, you have to have messaging to your doctor. It's changed my life. My doctor went there about 10 years ago, and oh my gosh, it saves visits, it saves time, it saves problems, and it's more accurate exchange. So it's interoperability among providers, interfaces with the people that get the care, and very important, is respect to privacy concerns. Because you start doing that kind of stuff, and believe me, there are people in the public legitimately concerned, especially now with the national NSA listening to my words right now, that we've got to make sure that people are guaranteed that what shouldn't be known about them isn't, and that the information is under their control. But I think that's solvable. Barriers in stage 2 are finally, at last, getting consensus on interoperability standards, which have been elusive ever since David Griola was at ONC. We had the council set up to work on it, but we never got it done. And then I think getting the proper kind of HIE support that allows the information exchanges to be the buses that we need, especially for the small practice that could not possibly work without a centralized data repository. And then business drivers. We have to make it interesting to do this, and the incentives will help, but we really need to make sure that for good doctors and nurses and hospitals that want to get in the game of modernization, it makes business sense for them to do data sharing, interoperability, development. We have an interesting development now, which is the regional extension centers are clearly more and more interested not just in information system redesign, but in care redesign, and wedding those 2 agendas of redesigning information exchange and redesigning delivery of care is just the right way to go. I think CMS will probably remain a good player here. Under the law, CMS has to translate the stage standards into incentives. I'm not a complete fan of incentives, but they do help. And there's interesting interactions that Farzad has now talked about that I don't know about because of prohibition on interactions with CMS for me, but interactions, for example, between the CPC program, the Comprehensive Primary Care Program, that's a wonderful exploration going on under the Innovation Center in CMS, and the linkage to the MSSP program, which is the Medicare Shared Savings Program. That's the ACOs. So you've been reading about accountable care organizations, which I'm happy to take questions about if you have any. It's a confusing arena, but it's a really important program. Over 400 accountable care organizations in the country right now, and they're going to be very interested in your work. They're going to be really interested in interoperability because that's where they're going to save their money, by not having Mrs. Jones bounce back in the hospital because her meds got mixed up at home. And they're going to be able to make money by making care better. We have to solve some problems on quality metrics. We kind of overshot, and there's a lot of quality metrics, and we're kind of driving the system crazy, and we've got to make progress on that. And of course, the privacy concerns will remain severe and need to be addressed with great respect. I think the most interesting, promising element of all of this story as it plays out, maybe this will be stage 3, is consumer mobilization. An activated public that understands what good care looks like, that knows how much they can do for themselves, that's supported to learn and grow like they do at NUCA, where spiritual healers and home-based care, all the name of it, that would change everything if the public comes along. I have stories to tell you about what happens when the patients really get mobilized, the families, the people get mobilized, and it's dramatic. And again, if I were in the IT world, I would work on that space hard, which is the enormous power that patients and families can have once they really understand what's good care and what's in their own interest. So that's the story of meaningful use connected to the story of health reform. I want to take 1 more minute of my candidacy. You've opened the door, so I'm taking your permission to ask you for help. I am a new entrant to the political world. I carry into this world a whole 30-year history of work on improving large systems. I know I can help. This is the state where it can best be done. I'm an executive by training, and I believe I could help us with your help. I am running a highly professional campaign. We're all over the state. Key steps are coming up. I will just say I would love your support through contributing to my campaign, berwickforgovernor.com. Berwick, you can remember a website, right? berwickforgovernor.com. And just your ideas, you know, at any time you can, and your help. My staff will be in this room. Do I see?
In the back.
In the back? Back there. Raise your hands. And if you are interested at all in what you heard, please talk to my staff. If you like what you heard, tell your friends, because I would very much like my candidacy to be even better known. If you don't like what you heard, please don't say anything to anyone. But I'll be happy to talk to you. So I think on that note, shall I stop and take a couple of questions? Would you like me to do that?
Yeah, please do.
Okay, I'm happy to do that. That will take a couple of minutes. Yes, ma'am.
I would just like you to comment on the incredible volunteerism that we're seeing from the healthcare community. I've never seen anything like this in 30 years myself.
It's extraordinary. I think a lot of people getting turned on and very interested about the change that's going on. And when I was CMS administrator, one of the most inspiring things to do was go out to small communities, rural communities, and hear the doctors talk about strong communities and how they really wanted to help them get involved. We're seeing a lot of people stepping up to this plate. The money that's gone into the RIEs, to the RECs and the HIEs, and this evolution of knowledge about mature information in healthcare is, I mean, it's the multiple in terms of the volunteer response is really enormous. We're always looking at the gap, but I'll tell you that the energy's there. This is one healthcare problem I think we're going to solve.
I've been following the longitudinal care coordination because to me that's the big piece. It's just amazing what they're doing.
And some of the demonstrations that are using community-based care transition models with churches and community-based systems and families, extraordinary what they're doing. We're starting to see the effect. Yes, sir.
Don, you mentioned a couple of big things, and I tend to agree with some of these premises, but I'm interested in knowing what you think is your biggest opportunity for change. You mentioned the need to move more toward a global payment type of reimbursement structure, and you also mentioned moving toward a single payer system.
Yeah.
I'm curious, which of those two do you think has a better chance of winning and why?
They're not contradictory. You have a single payer. The single payer still has to pay the delivery system. What I think a precondition to the healthcare we need is to wean ourselves from fee-for-service payment, one way or the other. The idea of everyone's paid to do more, you get more. If we were able to get out of that and say, wait a minute, you know, we really want people to be well and begin to link payment toward the purchase or the wellness, the support of the wellness venture, I think we would have tremendous energy and a lot of volunteers and a lot of intelligence going in that direction. Get out of fee-for-service as fast as we can, everywhere we possibly can. Now that doesn't solve the multi-payer problem. When you have as complicated a payment system we have with all those coding schemes, some of that gets better when you go to non-volume-based payment, but some of it doesn't. And single payer is interesting because it would allow us to, immediately would reduce administrative costs dramatically. Things would get far simpler for people giving care. And I think signals would improve, because if there's a single payer, and they're accountable, and you can't have a non-accountable single payer, but someone who works for you, they get to speak up and say, you know, we really want more prevention, and I don't see it yet, and I need it. At CMS, CMS is a single payer for elders, for example, and when I got the Inspector General's report on over-sedation of elders in nursing homes, I was one phone call away and pretty mad. I called everybody in the room, the gerontology community, the nursing home community, for-profit, not-for-profit, the home health care. We got around a table. I held up this report. I said 300,000 people over-sedated in nursing homes today as we speak. Two options. You fix it, or I tell you, we will fix it. And I know which one you prefer. And the action was amazing. I mean, all I was doing was speaking up for what I thought was the public interest. You get a single payer like that who's really got your back, not the back of, corporate interest. I think it'd be a system that could be more responsive than what we have now. So I see that as synergistic. Yes?
You talk about the importance of helping patients manage their chronic conditions. What are your thoughts about patient-generated data coming from devices and self-reported, and when that's going to get into meaningful use?
It's attractive in concept. I think you would know more than me what the data are showing of when that really works. I think we should take it one step at a time. The amount of information that's generated about people today is enormous, and it makes sense to me that if we had a way to capture that data stream. Now, we know it works in intensive care. Intermountain Healthcare did that. I visit the ICUs at Intermountain Healthcare where they're collecting literally thousands, tens of thousands of data elements on patients in ICUs. And I can now go, when I visited, you can go in a room and say, in this bed, in this ICU, what's the most common contaminant of wounds? And it turns out to be, E. coli, and and sensitive to this medicine, you're using knowledge in an ICU environment in a really, really sophisticated way. I should think that would be helpful for the management of chronic illness. It has to be paired with instruction to people about their own self-care, because the best way to use that knowledge would be locally. And you've all seen patients who, by not having that knowledge, they get into deeper and deeper trouble. So I'm favorable toward it. I just wouldn't want the research and investigation done properly, because the last thing we need is more complexity that doesn't add value. Maybe one more question, and then I'll have to go. Yes, sir.
You've talked a lot about interoperability as the next step in the journey.
It's not a prescription, it's a description.
Right. As someone in a future position of authority, to what degree do you see vertical integration within the healthcare industry as a positive step forward, or a potential risk?
Potential risk is big. We're seeing it as we're under the aegis of cooperation, which I deeply believe in. We want to be in a unified system in terms of movement of knowledge and patient journeys. Under that aegis, we are basically opening the door for some collusive behaviors around pricing and market concentration, which is really, really risky, and we're walking a tightrope here. I work with the Department of Justice and the Inspector General and the Federal Trade Commission hard on giving kind of a new terrain of play for cooperation in markets so that people could actually build real systems. And I'm afraid what I'm seeing is a little too much kind of taking the money and running. I think you need strong leadership here. As governor, I'll tell you, I would watch like a hawk. I think we have a good commission in place. We probably need even stronger legislation, but we cannot tolerate game playing on the guise of cooperation. But we do need cooperation. So integrated behaviors, yes. Collusive markets, no. I want to thank you very much. It's a pleasure to talk with you. My staff are back there and happy to talk with you even further. Thank you, Dr.
Please join me in welcoming Samatha Sawdon.
Hello, my name is Sam. A little bit of background about me. I started in healthcare in 2005 and started at the front desk of a cardiology clinic at Boston Medical Center and really enjoyed the patient care and the interaction. And from there, moved up to supervising and managing of multi-specialty clinics, as well as primary care for local area hospitals such as MGH and St. Elizabeth's. So from there, I decided that I really liked the quality work, and I really enjoyed the project piece, but not so much the management, and went into consulting to sort of help practices focus on those quality areas and sort of help them lead through the project management of making sure that you can implement things like meaningful use, PQRS, and other initiatives that are coming forward in healthcare today. The next slide. So a little bit about my company. I am from the Massachusetts eHealth Collaborative, which began in 2004, and we are certified as a nonprofit. We started with a lot of backing from other nonprofits and currently are still located in the Mass Medical Society building in Waltham, and they are really one of our major supporters. A lot of the people who helped us get going are still on our board and help sort of drive our mission for nonprofit and helping practices with adoption, as well as just moving forward, as Don Berwick just talked about, as to where healthcare is going. So the way we started was we were a nonprofit and we had 3 pilot sites. There were applicants, over 600 clinicians applied to try to be a part of this pilot. This is when implementations were still fairly new. So we chose 3 different sites in different areas in Massachusetts to sort of see what the difference of implementing the same system, which was ECW at the time. What would the challenges be based upon the different patient populations, the demographics of the area, as well as just the different specialties that would be presented in the 3 different pilot sites. From there, we sort of worked on mapping tools as well as tracking different quality performance data as the practices stayed live post-implementation to see if the implementation and the use of an electronic medical record would actually enhance their care and improve their processes and outcomes. Next slide, please. So since the pilot, we've really sort of branched out. Dawn talked a lot about regional extension centers. We do a lot of work with the states of Massachusetts, New Hampshire, Rhode Island, and New York. And our company actually runs the Regional Extension Center for the state of New Hampshire. So a lot of our work is as an implementation agent. As they sign up with the Regional Extension Center, our company consultants are sent out to help them assess their workflows, do gap analysis, implement workflows that will help them meet meaningful use, as well as do general education so that the providers understand why we're doing this, the details of the program, and really help them understand that government is not trying to tell them how to take care of their patients, that this program actually is general basic care that they are already doing. It's simply getting an incentive money and getting recognition for using this program and using their electronic medical record systems. We also did 300 physicians were implemented for Beth Israel, worked on that project. Right now, as we talk about the stages going forward, which we'll talk about a little bit, some of the electronic medical records are not going to make it. They're smaller. The criteria that is coming for stage 2 and stage 3, the smaller records are not going to be able to make it. So a lot of our work now has become conversion work. So for example, Harvard University has hired us to switch from their current system, which is point and click, to a new vendor, which will be able to sort of go through the long haul of the incentive program. We've also done a lot of work for patient-centered medical home and the medical home pilot up in New York, which also assisted 26 practices with connecting with their local state HIE, their health information exchanges. Boston Medical Center, we've done some primary care redesign as well as PCMH initiative. And again, a lot of our work right now is focused on that health information exchange, helping those organizations, advising them on the sort of infrastructure that they need to be on that federal platform, and also different ways of, setting up their connectivity, if they're going to either do a direct messaging or if they do a data repository sort of health information exchange. Next slide, please. So I'll talk fairly quickly about the American Recovery and Reinvestment Act, but you can see our agenda here. I'd then go into the Medicare and Medicaid incentive programs, talking about eligibility, the different incentive programs. I'll talk a little bit about meaningful use, the details of the measures, as well as sort of where meaningful use is going in the years to come. Talk a little bit about meaningful use in the medical practice, so how it relates to physicians, both small physicians as well as large hospitals or hospital-associated organizations. And then sort of putting all the pieces together. And then I'll answer any questions that you guys have at the end, but I may pause in between because there's a lot of information here. Next slide, please. So I'll breeze over the American Recovery and Reinvestment Act because I know Dawn talked a lot about it, but it was signed into law in 2009, and it was really to create jobs and provide some temporary relief for the industries that were really affected by the recession at the time. So it was, education, it was healthcare, it was roads, it was creating jobs. And part of the law had a specific enactment, which was that Hitech Act. And what it was is the Hitech Act gave billions of dollars to the states. So basically, $26 billion was given to the states for the incentive programs and to set up those regional extension centers. And then about $87 billion was given to Medicaid to help boost those programs and help them pay their incentives as well for if a provider goes forward with the Medicare incentive program. Next slide, please. So there's sort of a three-part aim of ARA and Hitech, and really they're looking to better healthcare, which I know Don talked a lot about. And how they're going to do that is through really focusing on capturing data about patients, looking at that data, running reports to see how we're doing on different performance measures, trying to find action plans and resetting our goals based upon how we're doing on quality data performance, and then ultimately reducing costs, that proactive care instead of reactive care, bringing that patient in to manage their diabetes and having their feet checked and all those different things before you have to lop off a leg because the doctor hasn't looked at a diabetic's foot in months, okay? So it's really sort of progressing. In 2009, we had paper records, it was sort of messy, couldn't find things, was this a patient on a medication before? Let me dig through an entire stack of paper to find it. To the Hitech Act, where now we have computers, and it should be easier to find previous medications with start dates as well as discontinue dates. And then moving into, hopefully, in the next phase, which is going to be that HIE and health information exchange. So that as my medications are changed, a notification is automatically going to be pushed to my primary care provider so he can update my medications and ensure that anything that he refills is in line and doesn't have any drug or allergy interactions with the information that he has in his record. So we're going to go into the details of the Medicare and Medicaid incentive programs. Okay? So while meaningful use is an incentive program, of course there is a stick. So right now, they're paying these providers an incentive to meet the different stages of meaningful use. If the providers do not meet meaningful use by 2015, they are going to start incurring penalties. So it's really important for them to look at who is their patient population. Do I have more of a Medicare population or do I have more of a Medicaid population? And really determine which of these incentive programs they qualify for and begin working, because the penalties will go into effect in 2015 for anybody who is not at least attested for stage 1 meaningful use. And they'll start at 1% and they're going to increase to 5% of your Medicare allowable charges, which is a decent amount. So the different eligibility here. So eligible professionals, we're talking about single individual doctors or organizations of like 10 or less, or even providers who are in a larger hospital organization, but they bill either under a group tax identifier or organizational ID, but have their own NPI. So the people who qualify for these programs are basically going to be your doctors of medicine, osteopathy, dental medicine, and surgery. So your Medicaid-only eligible providers are really going to be those ancillary providers that are going to help you, your nurse practitioners, your certified midwives, your physician assistants. So basically, if you're eligible for your Medicaid incentive program, you can get incentive payments for more of your provider staff than you would if you had the Medicare-only incentive program, because there it's just going to be your doctors. It's not going to be any of your mid-levels or any of those other providers that you're going to be able to collect this money on.